Doktor. Assalamualaikum.
Assalamu alaikum.
Assalamualaikum.
How are you?
Alhamdulillah, fine.
How is Ayam Dhul Hijjah with you? Hello.
Hello, yes, Doktor.
How is this days of Ayam Dhul Hijjah with you? It's okay?
Alhamdulillah, okay, Doktor.
Alhamdulillah. Don't forget to do fasting for Arafah.
Inshallah.
Inshallah. Let us start by Al-Kitab.
Alhamdulillah. Alhamdulillah. Ya.
نسأل الله أن يعلمنا ما ينفعنا وأن ينفعنا بما علمنا. In our religion, we must get a new knowledge, but to be applied, not just knowledge for knowledge. Of course, medicine is the most important. Let us start by the first group. To present the first case, please. Who will be the first one to present?
Sharifah will be the patient.
Okay.
And then I will be the student. The student.
Okay. Who will be the Oski?
Ski.
Me.
Zaid.
Me. Zaid.
Okay, Zaid. You are welcome. Yalla, let us go. You will have 20 minutes, up to 25 minutes. Someone can adjust the timing for collecting the history from Sharifa as a role player, a mother of a baby, from Naufal, inshallah. Okay.
Okay. Assalamualaikum, Madam.
Waalaikumsalam.
So I talked to the mother for the patient. Is it right?
Yes, yes.
Okay. Okay. What's your name, Madam?
My name is Aminah.
Damina. Okay. Okay. What's your child's name?
Nuha Tahsina.
What? Nuha.
Nuha Tahsina.
Okay. How old is it? Boy or girl?
2 years old, girl.
2 years old girl. Okay. So why she come to the hospital?
Because yesterday I noticed she had rapid breathing for 1 day duration.
1 day duration. Okay. So the rapid bleeding, is it throughout the day?
Yes.
Oh, throughout the day. Okay. And then is it now? Is she has resolved the rapid bleeding, or still have the rapid bleeding?
I don't know because she is in the what? I think it's awkward.
Resolved. Okay. So it start okay. The rapid bleeding start just yesterday, and then is it first time or is there any incident same symptom before?
No, this is the first time. But 3 days ago, actually, she has cough and fever.
Oh, okay. Mm, beside rapid bleeding, she has cough. Cough for 3 days. Okay, for the cough and fever, um, is she resolved or still have it today?
No, she has until
She,
today.
okay. Uh, for the cough, is it has sputum or just dry cough?
Yes. Has sputum. I noticed when she cough, there is yellowish or whitish mucus.
Okay. Uh, what's the frequency of the cough? Is it every time?
No, not every time. Intermittent throughout the day.
Okay. Uh, for the sputum is had blood or just is there
No,
any blood?
no blood. No blood.
For the fever, it is throughout these 3 days lah.
Yes.
Okay. So for the cough and fever, what did you do? As go to clinic and give her medication.
For the cough.
Mm-hmm. For
Uh,
the cough and
uh,
fever.
Second day of the illness, I brought her to the klinik kesihatan nearby, and the doctor there
Okay.
give shrub, paracetamol and cough mixture.
Syrup paracetamol. Is
Yes.
it resolved? Is it
No.
resolved?
No.
No, resolved.
Mm.
Okay. Uh, resolved. Okay. Beside that, is there any other symptom?
Ada symptom. She has runny nose.
Runny nose.
Mm-mm.
For 3 days also.
Uh, not 2 days, 3 days.
3 days.
The fever and cough 3 days.
3 days. Okay. Uh, okay. Mm, rapid bleeding. Okay. Mm, is there any like wheezing or whistling sound from the
No.
cough? Or no, no wheezing. Is there any for the cough? The sound is just like normal cough, or there's is some other sounds for the
Uh, I noticed when she cough, it's like her chest is go in deep
or deep
and cough.
inspiration. Uh, okay. For the other family members, they has same symptom, same problem.
Currently or previously?
Currently,
Currently no.
no. No family. Okay. So for the voice, is there any for the voice is there any hoarseness problem with the voice?
No.
No. Okay. Uh, how about the appetite? Is
I
it low?
noticed I noticed when she has the illness, she become lethargic, less active, and reduce oral intake.
Uh, for how about the is there any vomiting or diarrhea?
Daria, no. For vomiting, 2 episodes of vomiting after the cough.
The cough. Since when?
Since 3 days. Sama lah 3 days.
This okay. Uh, and then okay. Is there any like how about the urination? About the urinate? Any problem?
No. Everything is
No.
fine. Yes.
Uh, how about her weight? Is there any problem with her weight? Berat
Weight,
badan.
weight reduction.
Reduction.
I don't know. I do not notice any significant weight reduction.
Okay. Mm, for the is you any is there is you realize any factors that can exacerbate the cough?
I noticed she become worsen when she active and during the night.
Okay. Listen during night. I want to ask, is there any family history of asthma?
Asthma, no.
Asthma, no. Okay. How about immunization? Is she follow all the schedule?
Yes. Complete
Okay.
until her age.
Okay. Mm, I want to ask, is there any medical problem? Medical
Uh,
problem before?
Before, actually, this is the second hospitalization. For the first one, last
Uh,
month, she was warded for 2 days duration because she has acute gastroenteritis.
oh, okay. And then she is what? She is discharged after how many days?
2 days.
2 days. Oh, and then she is okay lah.
Afterwards, she okay.
Okay. Is there any other is there any other medical problem? Hello, madam.
No.
No. Like during the birth, is there any problem during birth?
During birth, actually she has jaundice, like yellowish discoloration of the skin, for 4 days duration, but she was not warded.
Okay. Besides that, is there any other problem?
For my daughter,
Yes, your
no,
daughter.
no,
Okay.
no.
During the pregnancy,
During
during your
pregnancy, no.
okay. Okay. Uh, how about feeding? Is she has breastfeeding or is until now is breastfeeding or the added food?
No. She breastfeed for 1 month duration only, and then for the rest she bottle feeding, and currently she on Fernleaf full cream milk, and also eat porridge, rice, chicken.
Okay. Uh, for the family, for other sibling, uh, she has how many siblings? And she has how many siblings?
She is the only one.
The only one. Okay.
Yes.
Okay. How about you and also your husband? Is there any medical problem?
No, but I have allergic rhinitis.
Allergic. Okay. Uh, how old are you
32
and
years
your
old.
husband?
Same.
Same. Okay. Your husband doesn't have any medical problem.
No.
Okay. Uh, how about the your child? The is she can now walking, running?
Yes. She able
Uh,
to walk, to run.
okay. How about the speaking language?
Speaking. Oh, okay. I think for her age.
Okay. Okay. So next, she okay. Do you work? Are you working?
Yes.
Uh, you and your husband
Yes.
are working as?
My husband work as a government worker. I
Mhm.
am a businesswoman.
Okay. So during your work, your daughter live where did she live? Is it at the
Uh, Initially, uh, I sent her to nursery until 1st October last year, 2019. But I stopped sending her and take care of her by myself.
Oh, so you brought her during with you lah during working.
Yes.
Oh, so why do you? Is there any problem why you stop send to nursery? Is it no okay?
Uh,
Is it no reason?
no reason.
No reason. Okay, okay. How about your salary? And sorry, I asked about it. Your and your husband income.
Actually, I don't know.
Oh, okay. Mm, so you has LG rhinitis. Okay. Fever. Uh, mm, for the okay, I want to ask about the cough and the rapid bleeding. Is there any specific time that it become worsen
During the night, it become
during the night?
worsen. Yes.
Okay. Okay. Mm, do you realize any problem with her skin? Like,
Uh,
is there any like rash on
no,
rash? No.
nothing.
Okay. Okay. Mm, mm,
I'm sorry to interrupt, but the time is up for 15 minutes already.
oh, dah 15 minit. Dah.
Yes,
Is
it's finished.
it's
Okay,
finish lah.
you can finish within 2 minutes.
Okay. Mm, so I want to ask madam, madam,
Yes.
for the cough, beside you give paracetamol, is there any other medication that you give?
I don't give medication, but I put some ointment on the chest, but it was not relief.
Okay, not really. Mm, during before the cough, do you realize any like the exposure to dust or any pets?
No, our house does not have any carpets, pets. But 1 week ago, my husband and I have fever, cough and sore throat. But we have fully recover.
Okay. So, mm, so this is the first time. Okay. Uh,
Okay, so what is your working diagnosis now?
I think my working diagnosis is bronchial asthma or basically acute exacerbation of bronchial asthma.
So
Secondary. Huh?
Can you make please summary of your case? Summary, short summary.
Okay, so this patient Nuha, 2 year
Short one,
old
please.
girl. Okay, 2-year-old girl come to the hospital because of tachypneic for 1 day duration. She also has a cough and fever and also runny nose for three days duration. Uh, 3 days duration. She also had lethargy, reduced oral intake, and also 2 episodes of vomiting after cough for 3 days duration. And then she had brought her daughter to the klinik kesihatan and was prescribed with syrup paracetamol and not resolved, and the symptom was not resolved. And then the mother had a history of allergic as underlying allergic rhinitis, and then the others, and then there's no family history of asthma. Okay, I think yang for the others is unremarkable.
So what is your differential diagnosis?
Differential diagnosis. Um, mm, Pneumonia.
Okay.
And then pneumonia. Right, bronchiolitis. And then pneumonia, bronchiolitis. I think that's all.
So what investigation you will do to confirm your diagnosis?
Investigation. I would like to do spirometry to check for any obstructive lung disease that can brought to the diagnosis of bronchial asthma. And then for full blood count,
Spirometry for 2 years old.
yeah, she cannot. Okay. Okay. First, full blood count first. I want to check for the any anemia, hemoglobin level, and then for any leukocytosis, I want to check for any leukocytosis. And then in asthma, I think there is maybe eosinophilia. Eosinophilia.
Hello.
Hello, yes, doctor.
What other investigations?
The investigation. Mm, bronchodilator reversibility. Is it can?
Okay, good. What is the name of this one?
What
What
is
is
meaning?
yeah?
if the symptom are resolved, it is it is bronchial asthma.
What is the relation with spirometry?
Relation
To spirometry. What do you mean by resolved or recovered?
For the bronchodilator will resolve the symptom of the resolve the symptom of the asthma.
Okay, if you are using spirometry, how much improvement did you suspect?
I cannot remember the there is improvement. I think
what are you doing? What are you doing? If you
I can't
don't know,
remember the
okay, if you don't know, then I don't know, or I don't
okay.
remember.
I don't remember. I think 12% of FE less than I don't remember.
Okay, it is 15 to 20. Yes. In other investigation is requested.
For I want to do chest X-ray.
Why?
Maybe I want to look. Is there any problem with the lung? Is there any like patchiness or consolidation at the X-ray? This can cause it maybe pneumonia or bronchiolitis.
So
And I want to sputum culture also.
just tell me, chest X-ray done now for your patient with asthma. What did you suspect to find?
For asthma, I think hyperinflation, but she is the first case, the first episode. In bronchial asthma, I think there is hyperinflation.
For bronchiolitis?
Bronchiolitis, there is some patchiness at the bronchial area.
What else?
I don't know.
Okay, what is the during examination? What is the most important system do you need to examine if you suspect bronchial asthma?
Respiratory examination.
Other than respiratory.
The respiratory,
Do you know something known as API?
Is it cardiovascular? Atopy? What?
API. Asthma. Asthma predictive index.
Oh, asthma index. I can hear. I can hear well.
So who can answer? What is API? Anyone knows what is asthma predictive index? I will choose. If no one answer, I will choose. Farha?
I'm sorry, doctor, I don't know.
Okay. So let us got a simple comment. Thank you, Sharifa. Thank you, Naufal. Really, you are a good job for that. Sharifa is a good mother. and she's giving a good history. And also it looks Naufal is very arranged man. He knows the steps. As a year 3, I appreciate your starting, but let us get some comment. It is for all, please try to make use of that. Number 1, you must introduce yourself
Oh, after this.
to the patient. I am blah blah. Second thing, you must do some empathy with the patient. Oh, so sorry, he is sick for how long? يعني كلمة sorry for the patient and the word get well soon like that is a كلمة طيبة which you will be appreciated here and thereafter. And the patient needs to hear something which is good. Okay? This is the number 2. Please try to be sympathize with the patient. When whatever is the patient is in a weak situation, especially if the sick one is his son or daughter like that, it is very painful time. Number 3, you didn't try to clarify Sharifa's concern from the start. Okay? As Madam Amina told you, my daughter have rapid breathing. Okay? What else? Is it the only one or not? She will try to tell you. If she doesn't tell you or she didn't tell you, you must ask yourself. Rapid breathing is a sign of respiratory distress. Yes. And for respiratory distress, we have RD score, which we are trying to know how severe is it. Okay. Which includes rapid breathing. Okay. Is there any chest indrawing, either subcostal, intercostal, supracostal, suprasternal retraction? It is very important. You must ask about, is there any grunting? Is there any nasal flaring? And the most important, is there any cyanosis? Does the child turn blue? All this is a sign of respiratory distress. So if you came to this thing, you must ask the mother, she has any other concern? I think mother like Sharifa will tell you a lot, okay? But you must try to concentrate, even by history, to get an idea about how severe is the shortness of breath. Because if it is severe, I need to start to intervene and go to ABC before I'm trying to only collect the history, okay? This is a very important. And also, so you asked her, is there any family history? She tell you current or previously? Still current. I don't know why you choose only current. If asthma or any other disease, you must ask about the previous disease in the family, the previous attack, okay? As I told you, in case of atopy, like asthma is the most common allergic disease, we must ask about other system which can put allergy, which is the skin. For eczema, even if you open the third edition of pediatric protocol, you will find the asthma predictive index, which includes dermatitis. Is there any eczema? It is very important one. Okay. Really, for vaccination, you asked. I know that you have a good flow. You know what is the next step to be done. But for vaccination specifically, you must ask. She got or investigation, especially BCG, the vaccine which is given to the standard to the left shoulder, to the left shoulder, yes. Is there any mark there or not? Because it is very important. You must see in every patient. And you must clarify, is there any extra vaccines? Because now we can give vaccination against influenza, against pneumococci, okay? Even soon it may be against COVID. So we must ask for any extra vaccine, okay? This is an important point. The other one, did you remember what is the definition of bronchial asthma?
Asthma. It's chronic inflammation of the chronic inflammation of the respiratory tract.
Okay, but there is missing important word, chronic reversible.
Reversible inflammation.
Yeah, that is the point which you speak about the BAFR. It can be improved after nebulization or like that. But it is recurrent, yes? Means the chronic, we cannot diagnose asthma from the first attack. Okay? And also there is some limitation to diagnose asthma in small children because most of the asthma-like disease in infants and toddlers is a viral induced with. Means it is just virus. It is not asthma. That's why in Malaysia here they retrieve the asthma predictive index, which can give you possibility that the child can get asthma at the age of 6 years. Okay, before continuing my points, I would like to see the OSCE, which will be presented by Zay.
Hello, is it clear? Okay, so for my OSCE here, I only managed to complete
Yes.
2 questions. And
Can you make it full screen, Zay?
for full screen. And then one MCQ questions. So the question is a 15 years old female presents to the operational clinic with in the history of cough and rhinorrhea. Then rhinorrhea has been improving, but cough is getting worsened, and patient has been febrile for the past 2 days. So she also reports of abdominal pain since yesterday. So the question here is because we are focusing on pneumonia. So what are the findings on an exam if present would help to rule in diagnosis of pneumonia? Then second question is what is the most likely organism causing this patient symptom? So for the first questions, is there anybody volunteer to answer the question? I choose one. Fatin Hanani, you there?
Yes. What are the finding on examination? I think on percussion, we can hear wheezing, and then on auscultation, we can hear that there is crepitation. And then on percussion might be there's presence of dullness, and in what about others?
How about vital signs?
Vital sign is since patient is febrile, there will be fever, and then patient might have might be in tachypneic, and then her blood pressure might be normal, and
I think that's enough. Thank you, Fatina and Nani. So should we go to the answer or anybody else want to try?
No?
I think let's look at the answer. So this is what. So in general, sensitive pneumonia are not specific, vary depending age, respiratory pathogen, and severity of infection. But the two hallmark is fever and cough. So this patient present with fever and cough, and then other sign and symptoms are highly specific but not sensitive for pneumonia, crickets, okay, and detection and necessary in infant. And then for vital sign, we can also look at the patient is tachypneic. So for tachypneic in patients in pediatric,
Hello? Hello?
hello?
I think yes. Okay.
Clear. Okay. Sorry for the internet interruption. So and then for upper lobe pneumonia, it's mimic symptom of meningitis with pain related to the neck. And then for lower lobe, so this patient complain of abdominal pain, right? So it might be lower lobe because of the referred pain from T9. And then we look at the second question. So what is the most likely organism causing this patient symptom? Oh, sorry. So anybody want to give a guess?
Strep pneumonia.
Strep pneumonia.
Ah.
Now why? Must be some reasons why.
Zaid, can you try share the screen?
Oh, sorry.
I think it is one of the commonest organism.
So the answer is correct. So most likely organism is Streptococcus pneumoniae. Rationale because our patient have fever, cough, and abdominal pain. This is suggestive for lower leg pneumonia. Because pneumococcal pneumonia typically is lobar and then presented with cough, fever, pneumococcal cough, sakit knee, and decreased blood cell fracas, as been mentioned by Katianan. And then it's often difficult to differentiate between atypical and bacterial pneumonia and viral pneumonia. This is just the explanation about viral pneumonia and atypical pneumonia. And then by looking at this table from PITS protocol, such as been mentioned by Naufal. So for this patient, she is 5 years old. So for 5 years old is preschool age, right? So the most one of the most common is Streptococcus pneumoniae. So last question, prevention of pneumonia in infants. Soalan. So the question is prevention of pneumonia in infants includes active immunization against which of the following pathogens? So that's the full question. What's vaccine that we give to infants that to prevent pneumonia?
D.
B. So the answer is A, DTAP, pertussis. Why not E, tuberculosis, BCG?
It is for meningitis.
Yes, correct. Because BCG is mainly for prevention of TB meningitis. So it's not really preventive against tuberculosis. So that's all from me.
You need to give us some, I mean by Oski, to add some pictures, please.
Oh, okay.
Like
Sorry.
picture of pneumonia, chest X-ray,
Yeah.
like signs of respiratory distress. Okay, like the patient with asthma, how he looks, clubbing, cyanosis. Okay. Did you finish that?
Yes, I'm finished. That's all from me.
But just I would like to ask for this last picture. It is very important. Bordetella pertussis is prevented by which vaccine?
AP,
DAP. DAP.
diphtheria, tetanus, pertussis.
Okay, so it is a part of DTP. It's very important. Okay, and it presents like small age, and with usually Bordetella pertussis will come like whoop. Okay, the child cough, 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 and then get after prolonged cough. But in the small children, sometimes it is not atypical and it may be presented by prolonged cough and vomiting. Haemophilus influenza is a very important, and now we have extra vaccine which can prevent it. It is very important. Okay, TB, you must ask, you must check every patient you see now about the mark of BCG vaccine and is it reactive or not. Respiratory virus, of course, is the most common cause of bronchiolitis. You must take care about that, and you must put it on the top diagnosis, especially in the first 2 years. Neisseria meningitis or meningococcal pneumonia like that can cause also chest infection. And the point which they speak about in the first slide, can I see it again, Zaid? No, the previous one.
Yes.
Yes. No, you wrote it can mimic.
Oh, this
Yes,
one. Okay.
yes. Just to clarify, if the patient got any infection in the upper lobe, it can precipitate like stiffness in the neck. So many doctors can think it is signs of meningitis because of that. Okay, it is very important because of stiff neck can be affected in many cases like meningitis, but you are going to do meningeal sign which can help you. Also, if it came down in the lower lobe, we must take care. It can affect, it can cause like vomiting because it irritates the stomach, or cause abdominal pain, which some doctors may think it is inflammation like appendicitis or like that, or can cause diarrhea, which is known as parenteral diarrhea. Parenteral diarrhea, we mean the problem is not in the enteral, is not in the gut itself, it is in the other system like lung, pneumonia, like ear, otitis media, and others. Okay, so inshallah at the end, Zaid, you need to offer us some slides, some clinical pictures about that. So now we can come to realize about the situation of respiratory system. It is very important because most of the patient will come initially by like mild fever, rhinitis, cough, vomiting, can be present in many indications and many diseases. So your way of collecting the knowledge will help you a lot to know where you are going. If the patient has a chronic cough, I mean by chronic more than 2 weeks, and he is losing weight and he got some sweating, and there is family history of TB, you must go for TB or other. If the patient has history of asthma in the family or eczema, the mother here who also has rhinitis, but to diagnose asthma, I need recurrent, especially in small age. I need at least, according to the asthma predictive index, at least 3 attacks of wheezy chest with other, either one major or 2 minor. You must revise that ABI in your pediatric protocol. Bronchiolitis, of course, may be the most common cause, but sometimes there is overlap between even all this and the common disease which known as a killer of children, which is pneumonia. And also pneumonia sometimes it can be a virus, not bacteria. So even we came to pneumonia, we must be able to say, is it viral pneumonia? That's why we are doing investigation like full blood count and other inflammatory marker. Okay, can be viral, can be bacterial, can be TB, can be atypical. And the atypical is a very common in small age and common also in school children. Okay, that's why if you are going to see one case of the respiratory system, you must know something about all cases. That's why you are able to diagnose your patient. And again, I am trying to revise you for any patient. Okay, you are going to examine. Number one, you need to observe him. Okay, observation is very, very important. If the patient looks normal, facial features or abnormal, what about his growth and development? Is an acute problem like severe respiratory distress or not? Is giving any medication or not? And vital sign if it's connected to monitor. Okay, and then you must go to examine him peripheral then central. I mean by peripheral, you will start by checking the hands, okay, for any cyanosis, for any clapping, for any tremors, whatever, okay, from front and from back, and then you are going to check the pulse and the blood pressure and the RR, so you mustn't miss the vital sign, which is very vital. and then you will come again to the chest itself and got inspection again. So you must do observation, and then you must start the peripheral and then come to the system itself. And for the system, you are going to start again by inspection, palpation, percussion, auscultation. Okay. For inspection, you must know what you are searching for. If the lung is very inflated, hyperinflated lung, it means maybe asthma or severe bronchiolitis. Okay. If there any scar, it may be the patient has a problem in the heart. Sometimes the heart presented as cough and a bit respiratory distress. Okay. Then you must do palpation, percussion, auscultation, and if you need to answer one question, which is the other signs which we can see in pneumonia, it is better to go through it by that way. The patient maybe his growth is not well, he may be dysmorphic like Down syndrome, he is immune, considered as immune incompetent, and then by vital sign I may find the patient has cyanosis or not, has clubbing or not, especially if bronchoectasis or cystic fibrosis, you can find this clubbing also. I will check vital signs by examining the chest. You must comment at the end by, even for auscultation itself, you must comment the air entry. Is it normal or abnormal? That's your job during the examination. Air entry is normal or abnormal. What about the breath sound? Is it vesicular or bronchial? And then you are going to comment about any added sound. If added sound is bronchi, it is different than if you can hear crepitation, because this will guide you to asthma or viral induced wheezes, and the other will guide you to bronchopneumonia. And is it unilateral or bilateral, which can diagnose either lobar pneumonia or bronchopneumonia. Okay, I hope now you are able to come to your reference and got a big review of the respiratory system with concentrating on our diagnosis today, but you must get a simple hint about the other diagnosis so you can build your ability with time. Now your turn if you need to ask any questions.
Doctor,
Yes.
does the API different from ages?
It is done already for younger children because we are very, very difficult to us to give the impact of bronchial asthma before 3 years. Usually we are using it before 3 years. So if the child got 3 attacks of wheezy chest and there has like eczema is enough, we would consider it can be asthma. And then even if we tell the family it is early to diagnose, but we need to start the treatment of asthma, hoping he will improve when he becomes elder. Okay. If we found the family history also of asthma, of eczema, of investigation-wise, you will find for the minor and the major, one clinical sign, one laboratory test, one from the history, you can come and revise it. Okay. Any other question? Good. So let us start by the second team today. Who is?
For the second session and second case, I will be the patient, not the patient, mother and woman will be the doctor.
I cannot see your name. Who will be the mother?
Fatin Hanani.
Anani?
Yes.
Okay. Who is the doctor today?
Me, Umi Khair.
Al Khair.
Yeah.
Oh, mashallah. Okay. And who is the one explained before? Oski?
Can we start now?
Oski?
Oski, Lailatul Nazira.
Okay. Okay, you can start, please. You have 20 minutes.
Okay. Assalamualaikum, Puan. My name is Umil Khair. I'm doctor here. Can I ask a few questions regarding your child condition?
Waalaikumsalam. Okay, sure.
May I know your child's name?
My child's name is Ali. He is 11 months old.
11. Okay. So, Puan, what brought your child in today?
Actually, my son had an episode of fitting for an episode of fitting, and it also associated with fever, where he had fever for 3 days already.
For the episode of fitting, does this is the first time this happened?
Yes, he never had this episode before.
Yeah, I know who witnessed the situation when the fitting happened.
Both me and my husband, we both witnessed the fitting episode on that day.
So the fitting occur at day 3 of fever, right?
Yes.
Was the your son asleep or awake prior to the fitting?
Pardon?
Was your son during at that time is he asleep or awake prior to the fitting event?
During the fitting event, he actually he is awake, and during that fitting event, he suddenly developed jerking of her up of his both head, leg and also his hand, where it added with the rolling of his eyes, but there is no drooling of saliva and clenching of the teeth.
Okay, I know what he did before the fitting happened. Is he
Something
playing
something similar that the normal.
or just lying
Yes,
on the bed?
just lying, playing with us.
Oh, okay. Did you notice any bluish discoloration on the skin
No, he didn't.
or at the mouth periodal?
No.
During the moment, what you did to your child, to your son during that moment?
Since this is an episode, the first time episode of my son having his fitting, at that time I cannot, I kind of lost, and I just calling his name repeatedly, and about 2 minutes after that, he suddenly conscious again.
Oh, so the fitting lasts for 2 minutes
Yes,
only?
yes.
Okay. When your son conscious awake, does he able to move his leg or walk?
Yes, he did, but I found out that he looks like like lethargic. He looks lethargic.
But still able to move.
Yes, he did able.
Okay. Did he had any head trauma before, head injury, falling from the bed?
No, never had that kind of episode
Okay.
before.
Okay. About fever, how you notice that your child got fever?
Actually, it happens 3 days ago. Since 3 days, where uh,
Okay.
when at that time he looks like not really well, and then when I touched him, it was warm, but the temperature was not recorded, and I thought it was the normal fever, but I didn't do anything at that time.
Oh,
And then the fever was actually lasted for 3 days, and um, and the second day of the second I'm sorry to tell you, actually the feeding was happened on second day of fever.
Second day of fever.
Actually, on the second day of fever, I feel like his temperature was higher than the first day. So, uh, plus he suddenly had that feeding episode. After that feeding episode on that second day, we rushed towards the nearest clinic at our home, and uh, he was prescribed with only the paracetamol, and only we give only the cold bath. But the fever did not resolve for a third day, although we let our son take that medication. Apart from that, my son also had cough, which together with fever since 3 days.
Of course. For the fever, does it gradual or sudden onset?
It was actually sudden onset, and as I said that we went to the clinic on the second day, and it was recorded to have 39 degrees Celsius for the temperature. And then the third day, since the fever did not resolve, and the temperature was kind of higher, we afraid that the feeding may occur again. So we go to the HDA. At the HDA, he was given paracetamol and also tepid sponging. And on the same day, on the second day, on the same day we discharged. Not discharged. We did not admitted. We go home on the second day, and then during late night, we feel like the fever was kind of getting worse, and we afraid that the fitting to occur. So we go to IMC.
Okay. Okay. You said that your son also had cough. It productive?
Yes.
Productive or not?
No, it not productive.
Or dry cough?
Yes, dry cough.
Is he had any flu, runny nose?
Yes, he did. And apart from that, I did notice Ali was unable to had reduced his milk. Usually, he drinks about 120 ml about 3 times a day. But during that fever, he was unable to finish that meal.
Oh. Usually, what amount of milk that he drink?
Usually, he drinks about 120 ml 3 times a day.
100. Okay. Okay.
But during
How?
that
Okay.
but during that fever, he was unable to finish the normally that he able to finish.
Okay. For the um flu, is there any rashes on his skin that you notice?
No,
No. Okay. Okay. How about his activity during 3 days ago? Did he unable to active? Not active as usual.
yes,
Always,
yes.
always
During that fever,
sleeping.
he did not really active like as usual.
Okay. Did he vomit, diarrhea?
No, he didn't.
Okay. Is there history of recent traveling recently?
No,
Okay. Okay. Did you notice any ear discharge?
no,
Oh, bruises?
no,
Okay. Uh, did he had shortness of breath?
no.
Okay. Okay, about the cough. Did you notice any blood, appearance of blood?
No,
Okay. Did he had changes in color of urine?
no.
How about frequency of the urine?
It is normal,
Normal. It is
like
normal.
usual.
Okay. Okay. So is there any muscle weakness that you noticed
No,
recently, 3 days ago? No.
no,
Okay. Okay. Did you notice any abnormal movement, like
no.
sudden? Okay. No. Okay. Is he was diagnosed with any medical illness before?
He was diagnosed with G6PD
Hmm. When he was diagnosed in birth?
after born.
Is there any story of previous hospitalization?
No.
Uh,
Except for after he was giving birth, he developed yellowish discoloration, jaundice. I
hmm.
think it might be secondary due to G6PD, causing him to admitted to an ICU for the phototherapy for
How
about 2
long?
days.
For how did that he admitted?
How he admitted?
How they? How many days?
How many days? 2
Uh,
days.
is he on medication or treatment?
No.
Mm, mm. He got did he got all the vaccine according to his age?
Yes.
Did he take he got extra vaccination?
Yes.
Yes. What is it?
I'm so sorry, I couldn't remember
Oh,
the vaccination.
Did he had complication from the vaccination injection? Is there any local rash, local reaction, inflamed? Okay. Okay. During pregnancy, is there any medical condition that you got?
No.
No. Okay. Are you attend all antenatal screening?
Yes.
Yes. Is there any abnormal was noted during checkup, antenatal checkup?
No.
No. Okay. Okay. How he was born? Either through cesarean section or
Yes.
vaginal delivery?
It was born about 40 weeks one day by a cesarean section with birth of with a weight of 3.34 kilogram.
Hmm. Okay. Did he got any complication during? Did you got any complication during delivery?
No.
Okay. So you said that he got neonatal jaundice, right? Okay. Okay. At his age, did he able to sit by his own or can walk?
Actually, he has started to walk, and he also able to scribble.
Scribble.
Indeed, he able to call a word like mama, papa.
Oh, to wait. Okay. Can he what drinking by his own or with your assistant?
He able to drink, but there's also spillage.
Or spillage. Okay. Okay, is there anyone or his sibling that also have similar symptom?
No, as he only had 2 siblings. He has a younger brother, which is 7 months only.
7 months.
Younger brother.
Okay, is there any history of epilepsy or neurological disorder in your family?
No.
No. Okay. May I ask your occupation?
My husband and I both works as a police officer.
Oh, police officer. Okay, police officer. How old are you?
I'm 27 years old.
Your husband?
29 years old.
29. So when you work, both your husband and you work. So who take care of your children?
My parents.
Or parents?
Yeah.
Okay. So where do you live?
I live in Camp Bukit, Galing.
So how about your family income?
We had a good financial.
Your house is okay. Did your house is equipped with the good basic amenities?
Yes.
Okay. Okay, before I end, I want to ask, do you have any ideas on what going on with your sign? What
I
do you think of?
I think my son having infection, some sort of infection, because he having fever, and then since the fever is the one that occurs first, I think fever might causing the fitting to occur.
Oh, okay. Okay, is there any concern that you want to express here?
Actually, I'm afraid that the fitting would be recurring.
Oh, so okay, about that, we need to confirm first the diagnosis. Okay, and then are you have any expectation from us in managing your son?
My expectation is actually high because my son is even still is only about 11 months, and I'm hoping that the treatment that will be given by the doctors in the hospital would be able to kind of prevent the recurrence of the fitting of my son.
Okay. Okay, I think that's all. Thank you, Poin.
Welcome.
Okay, thank you both. So diagnosis.
Diagnosis. Okay. Seeing this patient, Ali, 11 months old, with underlying disability, presented with simple febrile seizure, as he presented with generalized tonic-clonic, eyeball rolling up, and with a limb jerking, and it associated with fever, cough, and also flu, runny nose. So the working diagnosis here, I think of simple febrile seizure secondary to upper respiratory tract infection.
Okay, your differential diagnosis.
Okay, the differential diagnosis would be I worry of meningitis, encephalitis, head trauma. Is there any head trauma? Head trauma, and metabolic disturbance like hypoglycemia.
Okay, so you did a good job for the history, but did you try to rule these causes from the history?
I wrote up for
meningitis. How you rule it out through the history?
neck stiffness, but I didn't expect.
Encephalitis.
Encephalitis. Encephalitis. Encephalitis. I couldn't remember it.
Who can answer the difference between meningitis and encephalitis?
Is it consciousness?
Consciousness.
Altered mental, altered mental status.
Who can add? Please, anyone not using What is the difference between meningitis by the
Nausea, vomiting. Issues.
If the patient unable to look at the light, what is the name of this?
Photophobia.
Okay, if the patient has behavioral problem, it goes encephalitis. So sometimes you have mixed meningoencephalitis. Okay, so your rule now through the history, and this is the most important point. Usually we must come to the conclusion, is it simple febrile seizure? What is the thing, what things which can support that, what against? Because nothing now in the world is 100%. Okay, so you must ask yourself about that. Is it meningitis? So what is with that and what against? So this yours, even she said we are speaking about trauma. Did you collect the history of any fall down like that? Did you suspect any abnormal family dynamic which can lead to child abuse or not? So all this must collect it through the history. That's why our history give us about 70% of the knowledge, and it will clear in front of eyes that the most common diagnosis is like that. Can be, if we go deep, we can change our mind and do another cycle for questions to go the history, but usually it will guide us. Then we need about 20% for clinical assessment, and the remaining 5% may be for investigation. So this is the importance of history. So Umul, again, Umul.
Yes, doctor.
Yeah, its rule is very important. Keeping in your mind what is the most possible diagnosis for these symptoms. You're good, and you know that it can be just a simple, it can be meningitis, it can be trauma or child abuse, it can be metabolic, like hypoglycemia, it can be epilepsy, it can be whatever. So you must be able to ring the bell for everyone to rule out meningitis. So he's speaking about his position is normal, he's trying to do arching of his back, or he have a stiff neck, has got any abnormal behavior, he can look at light, or he is afraid and he is escaping from that, he did any behavioral changes, and this is number one. Okay. Number two, it is very important to Omul, for any convulsion, you must ask about three stations. The first station, what happened before, which is known as aura. What is the manifestation which appeared before the convulsion? Maybe they complain for you, he is doing some abnormal movement, is complaining from certain thing. He said that he can smell something, air also, like some visual abnormality. And what happened during the convulsion itself? Is it focal or generalized? It is tonic or colonic? Okay, it is very important. It will guide you. And then what happens after the convulsion itself? Is the patient gets like post-convulsive neurological deficit or not? Like Todd's paralysis, like hemiparesis, like whatever. So you must ask, and how long is it? Because some patient can get it very transient, but some patient can get it bit prolonged for a few hours or one day. It is different. So specifically for convulsion and fits, we must ask about any clue from the history for the diagnosis? Number two, is there any significance from pre-convulsive or convulsive or post-convulsive? And usually we advise to good video. If the family has someone witness, he can just do video for them because it is difficult to tell the mother or the father, go and make video for your child while he is convulsing. Of course, it is against his emotion. So if there is one member of the family witness, he can just go video for us. It will give us clear diagnosis what is the type, because she said simple. Yes. So how can you differentiate between simple and complex seizure, Hanani?
Simple seizure, in terms of duration, usually it is less than 15 minutes. Meanwhile, the complex seizure would be more than 15 minutes duration. And then in simple seizure, they will be generalized.
How can you differentiate between simple?
As for simple seizure, there will be generalized features of the seizure, like the tonic-clonic, myoclonic. Meanwhile, for the complex would be the focal feature, like only uprolling of the eye. And then in simple seizure, usually there will be no neurological problem after the simple seizure. Meanwhile, the complex seizure afterwards, there will be like thoughts, there will be neurological problems, like there will be paralysis.
What else?
And then, as I said first, in terms of the duration,
Sorry?
as I said the earlier is about the duration.
Yes, duration is very important.
Yes, less than 15 minutes for simple seizure. Meanwhile, for complex seizure will be more than 15 minutes.
Okay. So
Yes, doctor.
what is the definition of status epilepticus?
Status. Status epilepticus is a single seizure which lasts more than 5 minutes, or two or more seizures within 5 minutes period.
Who agree with Izza and who disagree? Alicia, what's your opinion?
Hello. Status epilepticus is when there is two discrete seizures, in between which there is incomplete recovery of consciousness.
So what is the definition again of status? It is two seizure without
complete without complete recovery of consciousness.
So the patient got one convulsion now and one convulsion after 10 minutes. She said 5 minutes. If 10 minutes is it status, or 5 minutes is it status or not?
5 minutes of continuous seizure.
What about you, Hafiz?
If I'm not mistaken, status epilepticus is a condition of a child when they are having seizure, and there is no and the condition is continuous for 30 minutes, and the
They said
patient
you came now to 30 minutes. So they started by 5 and then became 10 and now it's 30 minutes.
and the patient did not it has loss of consciousness, meaning that between the 30 minutes there is no, the patient is not realized. That's, if I'm not
No,
mistaken.
all of you have a piece of correct knowledge. Okay. The first one, she said 5 minutes. Yes, we are treating the seizure as if it is a status epilepticus, if it is in the hospital or coming to us in the emergency department. We suppose that it may not to stop, so we are planning for the same protocol of status epilepticus. But by definition, status epilepticus is both of the second and the third answer. So for ISA, yes, if the patient has convulsion for 30 minutes, which is that of Hafiz, or the patient for 30 minutes got two separate convulsions. He is not convulsing continuously, but he doesn't gain consciousness between them. So the two definitions are correct. Okay, either for 30 minutes or doesn't gain remission between, he has to without gaining remission within 30 minutes. But in the hospital, we must consider intervention. We are not see you in the emergency department and asking the patient how many minutes. They told you it's 5 minutes. Okay, let me go for 25 minutes to for Macan, for anything, and I will come to see his status or not. Am I clear?
Yes.
The second thing, which is very important, the A, B, C, D, E for resuscitation of patient with epilepsy. Okay. A is the
Yes, doctor. Secure the airway.
A, B,
B for blood circulation.
breathing.
B for breathing. C for the circulation.
D,
D for
your colleague said the metabolic causes. What is the most important metabolic causes? الخير.
Hypoglycemia.
Hypoglycemia. الخير. Why you are answering? Okay, so hypoglycemia is the most common cause. So in every patient has convulsion, even you are preparing your medication, you are supporting his respiration, ABC, you must ask someone to do the RBS. Why? The basal blood sugar level, because hypoglycemia is very easy to be treated if you picked it. Okay, just you need at the time to give dextrose infusion. No need for all. Okay, and take care, especially in diabetic patient, if there is child abuse, some mother need to kill the child, so she give him a dose of insulin, which cause for him hypoglycemia and convulsion. All this. So take care about that, please. Okay. So D, number 1 is the dextrose. Number 2 of the D is the
breathing.
No, disclosure, which I mean I must check the skin for many things. Number 1, is there any berberic rash? Do you know what is berberic rash? It means there is which is not fading. If I press over it, it is still there. Usually viral rash, it will fade. but berberic rash is not fading, which represent a severe infection like like meningococci, pneumococci, like that. Okay, so if you find the patient with convulsion with berberic rash, you must consider meningococcal meningitis. Okay, also if you find the patient has some manifestation in the skin like cafe au lait, like adenoma sebaceum, like hemangioma, as we have relation between the CNS and the skin. Before we speak about the relation between chest and the skin in the form of eczema, now what is the relation between CNS and the skin? Because both of them are ectodermal organ. And we have a 9 or more neurocutaneous syndrome. Its name is like that, neurocutaneous syndrome. Some manifestation in the CNS and the neurology, some manifestation in the skin. The most popular one, which we can see, I think we saw before many cases, which is the neurofibromatosis. Okay. So number 1 for D is the dextrose. Number 2 is the disclosure for any skin abnormalities. Number 3 is the neurological deficit. I mean, if the patient have like signs of hemiparesis, he got Todd's paralysis, he's got like cranial nerve affection, all this is very critical. If it happened even with simple convulsion, which stayed only for few seconds, but I can find other manifestation of neurological deficit, which is persistent for more than few minutes, I must consider it atypical or complex febrile seizure. Am I clear? So resuscitation of convulsion or fit is A, B, C, 3D. Now, it is 3D, not only 1D. Dextrose, disclosure, and disability. So please, the second lesson for us today, don't accept single diagnosis in your medical career. You must ask yourself, it looks like 100% bronchiolitis, but if it is not bronchiolitis, what it can be? It can be viral induced diseases, it can be bronchopneumonia, it can be blah, 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 blah. So I must ask myself through the history to collect some points. Okay? It is very important. The second thing, I must complete my history to rule out, number 1, the other causes. Number 2, the most critical situation. I mean here, what is the top critical causes which can cause fit? Who can answer? What is the most critical? Omol?
Doctor, sorry, what's your question?
Sorry, my question is, you are now in the emergency department and they found you, there is one patient coming to you convulsing in the ambulance and they close the line. What is the most important thing you must rule out or think about?
I don't know.
Who can answer?
Doctor,
Yes.
is it important to rule out any other intracranial hemorrhage that can cause seizure?
Okay, so number what is the most common? Is it intracranial hemorrhage? Yes, I agree. But number one, I must rule out the meningitis. So what did you suspect with meningitis? It is fever, neck stiffness, Kernig's, Brodzonski, abnormal sign. Number two, is there any increase in the intracranial pressure? This is the most important, the top importance. Is it intracranial, increase intracranial pressure? Because it can be secondary to tumor. Maybe the patient has brain tumor. It can be secondary to insult like bleeding, okay, or any space occupying lesion. So there is, or child abuse, okay, or the patient has epilepsy. So it is very important for any scenario, you must have mental rehearsement. You are concentrating what can be this case. Okay, I may make my life bit easy and said, yes, Malaysia is famous for febrile convulsion. Usually it is a simple febrile convulsion, hoping the patient will be okay and I will assure and discharge. No, it is not your rule like that. Yes, if you came to that, this is the best. But while you are waiting in the emergency, it is not a matter of selection. Everything like the rain will come to you. Okay? So always put the dangerous diagnosis, not to bother the family or make them irritable, but just to rule it. If you are able to rule it, it is very important. Otherwise, we need to tell the family, we need to do further investigation to rule out other causes, blah, 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 blah. I mean, need to do lumbar puncture to diagnose meningitis. I mean, need to do brain radiology, either CT or MRI to rule out any space occupying lesion. So this is the importance. This is your in the future. In every patient, you must say, can be a hidden severe problem, which if I didn't diagnose early, the patient may get bad prognosis. This is the issue. Like the same, I used to tell you an example about dehydration. Most of you are not imagine how can the diarrhea be the most common killer disease in childhood because of dehydration. The patient became dehydrated, he will get a lot of issue, shock, and then he can get acute kidney injury, and he can get electrolyte imbalance, and he can get a lot of issue which can lead to death. So if the patient came to me and the diarrhea, yeah, inshallah, it may be simple, don't worry. No, it is not like that. Because if you didn't pick the patient early with dehydration and the treatment, especially if he has persistent vomiting or loss of appetite, and start your IV fluid or even ORS if he can tolerate, the patient will be in danger. Because he may go for shock, may go for acute kidney injury, he may go for disseminated intravascular coagulation, whatever. So your responsibility is to come to the diagnosis and try to rule the worst scenario or the worst diagnosis. Am I clear?
Yes.
So please go through your pediatric protocol as I told you before or told for your colleague. The one who has protocol and who hasn't, it is like the one who has father and the one who hasn't father. If you have protocol, please go through it. It is very good and very informative, and it will help you. And don't think to change it unless you became one of the member to take decision to change, because it is a major study about all situation. Okay. Who will present now the Oski?
Me, doctor.
Yes, you can start, please.
Next question. Lepas tu next slide. The diagram. That way, who will give this question?
The screen, please.
Pseudomembrane formation over the tonsil.
Okay. Okay, the answer is red and red inflamed tonsils, and also the presence of that we can see by the diagram.
Nani, can you make it full screen, please? Okay.
The second is what are the causes of this condition? The organism that cause this condition, the inflammation of the tonsil. Is there anyone who want to volunteer?
Corynebacterium diphtheria.
Sorry?
Corynebacterium diphtheria. No.
The I'm not sure corynebacterium, but the most common for this tonsillitis or tonsillitis is by the viral infection, and the most common bacteria is by the streptococcus. Group A streptococcus. Okay, so next and then other than the viral and bacterial infection, there is also fungi or allergy. If the person is having allergy, if the patient is having allergies that affected the nose, and then can also affecting his or her tonsil. And also it is also caused by irritants like cigarette smokes or air pollution. And then the third question is signs and symptoms that are related to the condition that may be manifested by this condition. So want to volunteer?
Sore throat.
Okay, so try.
Dysphagia.
Dysphagia. What's more? Fever, yeah. What's more?
Hoarseness.
Yeah.
Lymphadenopathy.
Yeah. Okay, trouble breathing, ear pain, headache, nausea and vomiting, and also have red or enlarged tonsils and feeling lethargy. Can next slide.
No, please come back. Thank you for this nice picture, but it will give you an important maneuver for seeing one patient like that. Tonsillitis is one of the most common diseases in the outpatient clinic, but it is big different if you are intended to go deep and try to give the full service to the patient, or you just need to, oh, this looks like pus. It is acute follicular tonsillitis. Goodbye and good this medication. You will get well soon. Okay. I consider that most of the doctors are very busy, but it is not like that. Even if it is acute bacterial tonsillitis, you must ask yourself, is there any complication of that? It may turn to peritonsillar abscess. It can cause severe gastric upset, and the patient cannot eat, and he has persistent vomiting and need to be admitted for dehydration or and fluid collection. And you must ask yourself even, is it acute or chronic tonsillitis? Because if it is chronic, you may suspect a complication like rheumatic fever, which can occur from tonsillitis or even from pharyngitis. So if it is group A beta hemolytic streptococci, you must be afraid it can be complicated by rheumatic fever. And rheumatic fever, you know the criteria through John's criteria. So it is very important, even you diagnose a simple diagnosis, but you need to ask yourself, if it is not bacteria, it can be viral. Yes, there is infectious mononucleosis, which can cause membranous. It is not follicular disease. Membranous tonsillitis with another criteria of infectious mononucleosis. And we have an important criteria to differentiate between the viral and the bacterial tonsillitis. Okay, you must go through it, please. What is the name of this one is very important. Okay, how to differentiate between the viral and the bacterial causes of tonsillitis. Because it is not good for everyone to have the ability to just to write antibiotic. No, not the treatment is not always. This second cause. Third cause, as your colleague said, if you found membranous, this one is not complete membranous, so you must come back and ask the family, what about the vaccination history? It may be they are anti-vaccine, so you must suspect can be the diphtheria, and the diphtheria is a killing disease because the microbe will go to essential organ like the heart and cause myocarditis and heart failure and death. Okay, so it's very, very important not to accept a single diagnosis and try to go deep through the history again. Always remember that the history gives you 75% of the knowledge. You must ask the family, is there any history of anti-vaccine? Is there any history of rheumatic fever? Is there any history of family member with colonic tonsillitis? If your child has exposed to any viral, okay? What about his lymph nodes? So it is not just a simple open your mouth, oh, tonsillitis, start this treatment, okay? Second slide, please.
Okay, next. 8-month-old girl fully immunized with sudden loss of consciousness and seizure activity. Parents report 4 days of fever before but no respiratory or GI symptoms. She has a history of febrile seizures as a toddler. Otherwise, patient fatigue, alert, no distress or signs of dehydration, vital sign within normal limits, temperature 37.4, normal capillary refill and colour. Respiratory, abdominal and ENT exams are unremarkable. Her neck is supple and the neurological exam is normal. So based on the complaint, I think based on the complaint, we can, based on the complaint, what is the possible diagnosis of the case? So who want to volunteer?
Mm,
Naufal?
Hmm.
It can be simple febrile seizure since the patient has system like that.
Yeah. I think the possible diagnosis is simple febrile seizure based on the since the child is having fever before, and then she has a history of febrile seizure before. So the investigation should be performed on this patient for seizure. Who want to volunteer?
Blood sugar.
Yeah, blood sugar. And then?
Blood count.
For?
For the anemia.
Throughout the, I think.
Anemia and also infection.
Infection.
And
So, sorry, this girl is 8 months? Is it 8 months? Hello?
Yes, Doctor, it's mine.
But you said she has a history of febrile seizure as a toddler. So what is toddler?
To 2 years old.
Sorry?
One to 2 or 3 years old, if I'm not mistaken.
Okay, so it is up to 2 years. So what is the definition now of febrile seizure?
seizure that associated with fever, uh, more than 6 months, less than 6 years of age, no sign of meningitis, and no metabolic disturbance, and also no history of afebrile seizure.
Okay, so if there is history of febrile, it is okay, but this is the second attack. If she need to tell us the first attack is at 6 months, we can accept it can be, but if it is earlier than that, we must take care because the first one is out of the diagnosis of febrile convulsion. Okay, if we said this child now is 8 years, we will accept the diagnosis? Also no. Okay,
No.
so it is very important to please, for any disease, try to read the definition of the disease. It will help you. Okay, the most important, you didn't comment about the neurological examination is normal. This is the top importance. I mean here free of signs of meningitis, neurological deficit, upper or lower motor neural lesion. It is very important. Okay. Thank you. The next slide, please.
Okay, next slide. Okay, how to manage this patient, I think. Is there anyone to answer? Okay, no, it's okay. For this patient, for febrile seizure, usually it is brief and it's okay. Start je. For febrile seizure, usually it is a brief and ended and ended before the child is being assessed. However, if the seizure does not stop, we have to treat them with intravenous um, anti-epileptic drugs. Okay.
Why?
However, if we if the patient is having seizure due to infection, but we have to treat the infection first. For example, if the patient and also we have to exclude the underlying before we treat the patient, we have to exclude the underlying causes of the seizure, such as meningitis. So we have to treat the meningitis first and then proceed with antibiotic. So that's all.
No. The issue is not going by this sequence, please. The most important,
Okay.
if it is short-lived seizure, less than 5 minutes, no need to give antiepileptic. Okay. The second thing, if the diagnosis is very clear that you diagnose it as a viral rash or a simple flu, okay, you just give antibiotic and ask the family to will hydrate the child by oral drinks, and you can follow up him. But you must take care if you suspect another diagnosis. If you are unable to define the focus and you are afraid it can be evolving severe, because you can also admit, and sometimes you are admitting only for social cases. Suppose this patient is orang asli and you are afraid, if you tell them, the family, don't worry, and if anything happen you can come back, and he may not be able to come back, so you must take care, because you are not be a doctor only, you will be a multidisciplinary. You must be a social person, you must be a judging one, you must be helper one. So sometimes we need to admit, because no one can take care of the child. The mother cannot understand the situation. We feel that the best interest of the baby to keep him like 24 hours to make sure there is no more convulsion. Okay? So please take care about your decision. Yes, I agree. If the patient is very mild attack and the family are educated and they are near to a medical service within short time, I can even assure and tell them goodbye and insist for them either go to the nearest clinic or you can come to emergency treatment and ask for the pediatric specialist at that time. It is very important. Okay. Another slide, please.
Okay, Susan, a 10-year-old girl present to accident emergency, reported to have had a generalized tonic seizure while on an aeroplane. It has stopped by the time she is seen by the ambulance staff, and she has fully recovered by the time she reached the hospital. Her delivery was normal and full term. Early developmental milestones were achieved at a similar time to her older sister. She had recurrent otitis media between 2 and 5 years of age. There have been no concerns since starting school. However, similar incident happened before when Susan was sleeping and her mother noticed her face contracting to one side, then her right arm stiffened and this for 40 minutes. So, complain. Or how can I give the answer? Can you guess the possible diagnosis?
Is it epilepsy?
Yeah, epilepsy. So, second, what investigation should be performed for this patient? It is similar to the previous case. Okay, and then the last, how to counsel the patients about pediatric seizure. Is there anyone to give opinion how to counsel the parents? Hafiz? Sharifah. You want to give opinion how to counsel the parents about pediatric seizure?
I think the most important thing is the parents must always monitor their children because for example do not allow their children to swim or to do anything that can cause when she has the seizure, it can treat their nyawa, treat and cause death.
Okay. From what I have read, we have first to counsel the parents by first safety, which is if the child in is fitting, we have to place the child in a position that is safe for them and do not place anything in the child mouth, such as a spoon or stocking or anything. And then we have to counsel the patient with the risk of recurrence. We have to tell the parents that if uh, uh, of recurrence, recurrence is to first we have to counsel the parents by with the safety and then risk of recurrence. Okay, so that's all.
Sorry for that. Number one, she is 8-year-old. Yes. So she is out of the age of febrile convulsion. Her developmental is normal, but she has repeated otitis media before, or recurrent otitis media. What can it, if she has this recurrence until now, what may be the cause of it? Someone has recurrent otitis media. Sorry? We must suspect meningitis. The microbe is near in the air. Sometimes it can cause mastitis and it can progress to the meningitis. So we must rule out meningitis. If the patient has recurrent otitis media, we must take care about that. But the most important thing here is the mother noticed before that the right arm are stiff and jerked and soon involved her whole body. What is the type of this convulsion?
Focal to generalized seizure.
Focal to generalized seizure. Focal to generalized seizures, we must take care, please. Usually, we must rule out increase any intracranial cause by CT, by brain image, CT or MRI. Okay, because if we suspect this patient has brain tumor or space occupying lesion, it will come with recurrent until it is completely untreatable. We saw some cases like that. The patient had chronic headache and the doctor trying to diagnose him as migraine or stress headache and giving him sedation for long time. When he came to us, he started to get neurological sign and we diagnosed brain tumor which cannot be treated. It was unable to be debulked. Okay. The other thing also, which is very important to consider, the CT or MRI brain image if you have focal neurological sign. So you must put in your differential diagnosis, yes, can be epilepsy, but still it can be space occupying lesion, okay, which is very important to be ruled out. Counsel the family for seizure is very important, and it put another rule of you. You are not only doctor, you must be a social one who must give the family a good time. Just remembering you, we have one patient with epilepsy, newly diagnosed, and the doctor who is prescribing forget to tell the family that issue, because upon discharging any patient, you must have action plan. Like for asthma, you must have asthma action plan. For case of seizure, your action plan is to teach the family, number one, what to do during a convulsion. Number two, her medication maybe continue for two years, and she mustn't cut the medication until the doctor inform her. So the doctor forget for that. So the mother went to home. After 1 week, there is no convulsion. She stayed another 1 week. Alhamdulillah, my kid now has no convulsion. So she stopped the treatment. And they came to us after 48 hours by status epilepticus. Why? She said, no one insists to be for a long time. I think I will get it until my child is free of it. And now she is free for 2 weeks. So that is why communication with the family, education of the family is a very important thing. And it is one of your responsibility. And it is one of the way to get acceptance from Allah to make it itqan for your job. I mean, he must be very professional in his job. Okay? Hoping you pick the simple points which I try to touch it, which help you, inshallah. You are going to be in the clinical activity for about 1,000 days. Try to make use of every day to get new knowledge about one case, about its differential diagnosis, about each cause, about each complication. It is your job, please, to build your clinical sense, because the clinical sense is your future. Hoping, inshallah, the best for all of you. And thank you for this nice presentation, and see you again soon. Assalamu alaikum warahmatullahi wabarakatuh.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
You are welcome.